Thanks, Jeremy, and thank you for inviting me to present on the seminar. So I'm going to speak today about efforts to move towards best practice in management of STIs. And it's going to be a bit of a public health and clinical practice combination talk. So we'll switch from one to the other. And the focus is really going to be on the discharge syndromes and not so much on syphilis or drug-resistant gonorrhea, because I think those are topics that deserve their own attention. So I think we all know there's a large burden of STIs across the world, in particular when we look at Chlamydia, gonorrhea, trichomonas, and syphilis. And if we look at the distribution across the world in the bar graph on the left, the African region is really the most affected region if it comes to prevalence of STIs. So other than Chlamydia, which is the black bar, the other three bars are the highest in the world. So we've got the highest prevalence of gonorrhea, trichomoniasis, and syphilis across the world. And as much as we bear the largest burden of infection, we really struggle with our control programs and trying to address some of these complications. So what's quite interesting is when we look at the South African situation, and it's actually a very sober message. So these are data from a modeling exercise where we worked with the WHO and NICD and other stakeholders and really plotted some of the data that are available for gonorrhea, chlamydia, and syphilis. And when we look at these estimates, and they're largely research estimates from different settings, so different groups of women and men, different populations. But when you put those in a model that was developed by WHO and actually applied across the world, you get to an average population prevalence estimate. And these are the two solid lines in the middle of the two graphs. So on the left-hand side, we see the Neisseria gonorrhea prevalence in women, which is about 6.5%. And on the right-hand side in men, which is about. So it's much higher prevalence perhaps than we thought. And the reason that it's a bit higher in women than in men is that women are more often asymptomatic, and therefore the duration of infection in women is longer than in men, and hence the higher prevalence that we see in women. But it basically means that roughly 1 out of 18 women has a gonorrhea infection at any given point in time. And when we look at chlamydia, the graphs look the same. So we see the same prevalence estimates, where for chlamydia, it's about 15% in women. So 1 out of 6, 1 out of 7 women has a chlamydia infection at any given point in time. And in men, it's 6%. So it's 1 out of 15. Now, the sober message from these graphs, and the chlamydia graphs look the same as the gonorrhea graphs, is that these lines are flat lines. So if you look at the prevalence estimates, those solid lines are pretty much horizontal, meaning that for the last 30 years, from 1990 onwards, we've not managed to change anything in the burden of STIs in South Africa. So despite the rise of the HIV epidemic, despite all the prevention campaigns and efforts that we've launched for HIV, we've not been able to impact on the STI epidemic in our country. And one of the reasons is the lack of diagnostics that I'm going to speak about later. So this is a very sober message for me. If we think of STI control in South Africa, really something has to change, or something major has to be done to change the course of infections in our country. So if you put this to numbers, so if you put the prevalence to incident numbers, we roughly have about 2.2 million cases of gonorrhea each year in the country, and close to 4 million cases of chlamydia. Gonorrhea is a bit more often symptomatic, so the estimated number of symptomatic cases is larger than for chlamydia. But if we look at treatment coverage, it's actually very low. So based on the available data, we don't even treat half of the gonorrhea cases. Burden of untreated STIs in the country that really pushes or results in this unchanged prevalence that we've observed for the last years. Now, there's also a success story. So we did a similar exercise of active syphilis. And there we have seen a strong decrease in the prevalence of syphilis over the last 10, 20 years, especially in ANC. So most of the data are from ANC, but also in some of the other surveys and blood donors, for example, where we looked at syphilis prevalence. And there's two main reasons why this syphilis prevalence dropped over the last 20, 30 years. And one is the introduction of syndromic management, and I'll speak about it a little bit later, where we have started treated all the ulcers for syphilis. And the second reason is the introduction of antenatal screening. So the introduction of diagnostic testing and the comprehensive management of genital ulcers have really resulted in this strong decrease in syphilis prevalence in the country, which shows that by strengthening case management and by introducing diagnostics, we can actually have an impact on the STI epidemic. And those two features are gonna come back in the rest of my talk. Now, I just want to highlight, and that's the last thing I'm going to say about syphilis today, is that we all know about the elimination of mother-to-child transmission targets for congenital syphilis. And South Africa has made good steps in that direction. But there's also some recent data from NICD that do show a rising trend in neonatal syphilis cases. And coupled with the current BPG shortages, there's again shortages also here in the Eastern Cape. Our reason for concern whether we continue on the track towards EMTCT of congenital syphilis, or that is actually going to be a bump in the road. But overall, I think syphilis has been a success story through strengthened case management and introduction of diagnostic screening and testing. Now, the global STI response has, so the WHO has acknowledged that there is a large burden of STIs and has really put together, in line with the End HIV epidemic approach, a sector strategy towards ending STIs. And they recognize 3 priority STIs and 1 priority activity. So the priority STIs are gonorrhea, syphilis, which we spoke about, and HPV. I'm not going to speak about HPV today. There's still a lot of work to be done in that field. And from a programmatic perspective, really to focus on strengthening STI management as an HIV prevention effort. So it's not only about drug resistance, it's also about HIV prevention and linking the STI field to genital health, sexual health, and HIV prevention. So why are we worried about these STIs? I see actually all kinds of green lines on my screen. I'm not sure where they come from. That's weird. So we're worried about...
I think it was a different participant. I'll see. It looks like someone called Patrick drew it on. Patrick, if you could answer somehow, that would be great. Otherwise, I'll see if I can do it from my side. Sorry, Remco.
Yeah, I'll carry on. I just wonder whether... Anyway, it's fine. So we're worried about STIs for morbidity. So these, yeah, there's more lines. It's quite cool. Patrick is drawing. I'm not sure who Patrick is. This is so cool.
So I haven't done it before. Patrick, you should be able to undo or delete the whiteboard stuff. I don't know if I can do it from my side as host, but I'll look into it as well.
It's in, yeah, I'll carry on. So we're worried about genital tract morbidity. Really the STI associated symptoms, not only discharge, but also PID and the malignancies associated with HPV, for example. But also definitely the psychological burden. So when people experience discharge, it really puts stress on your relationship and on your psychological well-being, where people start asking questions around their relationship in the future. The other concern is reproductive tract complications. So these untreated STIs are associated with tubal factor infertility and an increased risk of ectopic pregnancy, both through closure of the tubes as a result of chronic inflammation. There may be some effects on fertility or male fertility, but those are actually very poorly understood and not well studied. So there's definitely a knowledge gap on the effects of STIs on male fertility. Then pregnancy outcomes. There's more and more data that show that untreated STIs and especially the inflammatory processes associated with it are associated with adverse pregnancy outcomes. So both miscarriage on stillbirth, but also with increased rates of preterm birth and low birth weight, as well as neonatal infections. So there's several studies now in the way, including a trial that we run here in East London that look at STI screening in pregnancy to hopefully improve some of these birth outcomes and reduce the rates of preterm birth and low birth weight. It's a complex interplay of factors between STIs, microbiome and chronic inflammation, and hopefully we see some positive effects of active STI screening in pregnancy on these birth outcomes. And last, there's an impact on HIV transmission. So there's an increased transmission if someone is HIV infected but not virally suppressed, so an increased infectiousness, as well as increased HIV acquisition if exposed. And these processes are simply the result of an increased concentration of inflammatory cells in the genital tract. Then the specific cause for gonorrhea is, one of the concerns for gonorrhea is antimicrobial resistance. So I think we're all aware of the global concerns about the emergence of untreatable gonorrhea. I think the situation in South Africa at the moment is quite stable, and I'll speak a little bit about it later. But definitely the concerns of untreatable gonorrhea are part of our concerns around STIs. So the standard of care for STIs, as we all know, is syndromic management, which basically means we give an empirical combination of antibiotics that covers the most likely etiology, which is relatively cheap, easy to implement, and actually, if you look for symptomatic infections, the performance is not that bad. So the main syndromes that we distinguish are the genital discharge syndromes, so miliary arthritis syndrome and vaginal discharge syndrome. And these are treated with a combination of azithromycin, ceftriaxone, and in case of women, metronidazole, and in men only metronidazole if their female partner has discharge, and a partner notification. So our syndromic management goes through simple algorithms, which you can see an example of on the right, and a combination of antibiotics. So for genital ulcer syndrome, we combine BPG with acyclovir, and again, we give a partner notification. So if we look at genital ulcers, the syndromic approach actually really worked well.
I can't seem to clear it. Do you want to maybe just unshare and share again and see if that does it? I'm sorry, I haven't had this before.
Yeah, it's gone now.
Perfect. Okay, great. Sorry about that. Cool.
Amazing. So I think syndromic management has done really well for treatment of syphilis and chancroid as well. So there's some nice data now that really show that the diagnosis based on clinical presentation of genital ulcers is quite unreliable. So sensitivity and specificity of the ulcer appearance for its etiology is poor. So one should actually not make treatment decisions on genital ulcers based on the clinical presentation. And in that sense, syndromic management for ulcers has really helped because quite a number of cases of syphilis and chancroid that would otherwise have remained untreated or misclassified as herpes infection were treated or are treated with the syndromic approach. So for genital ulcers, syndromic approach actually has done quite well and is one of the reasons we've seen a reduction of syphilis. For gonorrhea and chlamydia, it's a bit of a different story. And the same for trich, because a lot of these infections are asymptomatic and remain untreated. And that's for two reasons. One is that symptomatic infections may not be treated or receive the correct treatment. And the second half is our asymptomatic infections, which we miss with our syndromic approach. So how can we close that gap? So first of all, we're not going to blame COVID for change. I know we blame COVID for a lot, but we can't blame COVID for the gap in STIs treated. And I think this is quite nice to show an analysis of the MUS, so miliary arthritis syndrome cases over the last couple of years, where we always see a fluctuation of cases over the year, with a strong drop during lockdown. But by now, and actually quite soon after lockdown, the levels of MUS that were treated or are treated at our public facilities have returned to normal. So COVID is not a reason for this gap in STI cases that are treated. So to close the gap, I think there's three things we should consider. And one is really to get the basics right. The second one is to think of diagnostic tests. And the third one is really to strengthen case management and our treatment algorithms. And I'm going to talk through these one by one. So getting the basics right is really, especially when you work in the public sector and in the more rural areas, is really a measure of working with the clinic and working with the community and generating awareness and removing some of the barriers and stigma around accessing STI treatment and care. So this is a nice project that we conducted a couple of years ago in Limpopo, and the reason that I'm bringing it is that it's a good example of what we see happening in a lot of our communities and here in the Eastern Cape as well. So what we did at that time was community mobilization of individuals with genital discharge. So we basically put up posters at the clinic. We worked with the traditional leaders. We worked with the community healthcare workers and basically said, on these two particular days, there's going to be an expert team at the clinic, and anyone with any discharge symptoms or anything else can come and consult. And to our surprise, we got a lot of people coming to the clinic on these two designated days. So we actually managed to a large number of symptomatic individuals. And we did this at 6 clinics with their catchment area, so quite a nice representative sample. And when we calculated that back to population size, we found that 1 in 350 people actually had untreated MUS or VDS confirmed by physical examination. So that's a lot of people if you think of the South African population size. And most of these people that we got to the clinic had an STI diagnosed through lab testing. So we actually stumbled upon quite a large burden of untreated STIs in these 6 communities. So one of the things we did was ask these people why they had not consulted or why they did not seek healthcare for their STI-associated symptoms. And one of the main things that came up was that people were not aware. One of the main reasons was people are not aware that this increased discharge or presence of discharge or dysuria is not a normal presentation. And for me, it highlights the importance of community education and awareness, but also the importance of screening. Because if we don't ask or we don't make people aware, they might not self-report these symptoms, which we very clearly saw in these communities. So patient awareness and self-reporting, I think, are 2 important things to look at. The second thing we saw is that there's quite a lot of healthcare associated factors. So it has to do with trust in clinic staff and disappointment with clinic services. And it's the stories where people feel stigmatized or feel proper barriers to access care. And I think we all acknowledge that sexual health has certain barriers across the healthcare structure. There's one slide missing, sorry. And then the third component was treatment-related factors. So we saw quite a lot of people that were disappointed and had persistent symptoms or recurrent symptoms. So they actually had been to the clinic to receive treatment. It hadn't worked, or the symptoms had come back, and they had basically given up. And these factors really show us that it's important to invest in strengthening case management and reducing some of these barriers that both our patient and healthcare providers are related, so that people can actually access STI care. So one of the things that is important in that context, I think, and we don't often speak about it, is provider-initiated screening. So we do screen, as you know, for HIV infection, but often the STI program falls off. And it's definitely worth screening for STI symptoms in an appropriate manner, really in a way that people understand what is being asked for, and actually feel safe space to report or to understand or be aware of the symptoms that you are looking for. I mean, one of the good examples for me is if you look at the HIV stationary, for example, and there's this STI symptom question. I don't think I've ever seen anyone tick the box that someone has STI symptoms. So I don't think we're doing that screening properly. We usually ask if people are healthy, and then we tick the box that it's not there. Now, if resources are available, an alternative option is really to do diagnostic screening. And there's more and more push towards diagnostic screening in high-risk groups, if these resources are available. And these groups this screening would be based on a burden of STIs and the anticipated impact. And in the draft guidelines that I've put at the bottom, and I won't go through the table because it's a draft, we really have tried to put together some recommendations for screening for these STIs, as well as syphilis and HIV, on a regular basis in these high-risk populations. So when we look at treatment, we've got our syndromic management as the standard of care. And just as a reminder, these are the three main syndromic management regimens. On the left, for sexually active women, which means sexually active in the last 3 months. And if there's any discharge, we usually give azithromycin, ceftriaxone, and metronidazole. Then for the sexually non-active women, we've got metronidazole, clotrimazole, and then for men, it's azithromycin and ceftriaxone. So these algorithms are actually very simple and should be very easy to implement. And we should see good results of syndromic management. Yet, as you know, we saw in our Limpopo project a lot of people with persistent or recurrent symptoms and disappointment. So one of the reasons is that we actually don't do well. So as easy as STI treatment and our syndromic guidelines are, I don't think we do the basics right. And as a start, for example, a physical examination, which should be absolute part of any workup of STIs. And this was a study done with patient actors. So they sent actors to the clinics with an STI story, and to see how they would be managed. And as you can see here, only about half of the men and women actually got offered a physical examination. So we don't do physical examination of our STI patients, and it's quite a problem. I mean, in my experience, people speak of having water or having sores, but if you don't look, you don't know, and often you find something completely different from what a person tells you. So a physical examination absolutely essential in the workup of any patient suspected of STIs. The second thing we don't do right is treatment in line with the guidelines. And this is the same project where 70% of men got treated in line with the guidelines and only half of the women got treated in line with the guidelines. And it shows us that even though these syndromic algorithms are quite simple and easy to follow, we really struggle to treat or to use these guidelines for effective management. And there's several reasons why this doesn't always happen. It has to do with availability of drugs. It has to do with reluctance to give ceftriaxone injections or have a ceftriaxone injection. But quite frankly, this is not a good state of how we implement our guidelines. So getting the basics right, we should definitely start by strengthening our current guidelines. So in that line with that as well is, and I mentioned the ceftriaxone injections already, we should really not be giving anyone ciprofloxacin with discharge. We've got high rates of gonorrhea, ciprofloxacin resistant gonorrhea in South Africa. And as much as people may be reluctant to give injections, ciprofloxacin is really not the answer. And we still see a lot of patients that come, usually from private practitioners, that have been given ciprofloxacin for discharge. Discharge doesn't go away, and then they end up at our facilities. So really, ciprofloxacin should not be considered in any patient with discharge. There's two other pitfalls in the diagnosis or in our syndromic management guidelines. And one is the issue of metronidazole in women. So the metronidazole in our syndromic management regimen is given for trichomonas infection and has some activity for bacterial vaginosis as well. And as you know, we give a single dose, so the syndromic management regimen currently is a single dose of metronidazole. But this is not as effective as a course of metronidazole. So if you look at the table below, with a single dose of metronidazole, we still see 20% of treatment failures. And that's quite high, because if we treat women with discharge and we don't tell them that this stud dose or this single dose treatment might actually not work, they will be disappointed and they might not come back. And even with a 7-day dose, the cure rates are better. So they're around 10%. So it's 10% better than 45% less treatment failures. But nevertheless, we still expect 10% of women with a trichomonas infection to fail treatment on a course of metronidazole. So in an ideal world, one would give a course of metronidazole, and you may know that that's sort of the backup step in the algorithm. But even so, we still see 10% treatment failures. So if someone has a symptomatic trichomonas infection, the metronidazole might not do the trick. And the challenge then mainly is what to do, because without diagnostics, it's very difficult to decide what treatment to offer women with persistent discharge. Second pitfall in syndromic management guidelines, I think, is especially the women, where we know that only half of the women with discharge actually have an STI, and the other half has either got bacterial vaginosis or candidiasis, and we see a lot of vaginal dysbiosis and BV in these women, with or without an STI included. And this means that if we treat these women with STI treatment, there's a good likelihood that this treatment may or may not work. And if we don't educate our women about the management of discharge and that these conditions are not necessarily an STI, we're going to lose them to care. They're going to be disappointed and not return to care. So in education, especially around vaginal discharge, is very important. And personally, I think we really get it wrong in South Africa, where we brand discharge as an STI, where people are treated with the STI algorithm, where we collect statistics on STIs. But actually half of the cases in women has got nothing to do with an STI. And if we don't tell these women, it really puts pressure on their relationship and other things. So proper education around the etiology of discharge is essential. Now, to say a little bit about recurrent or persistent symptoms, and I'm not going to go in detail on this today, it's actually a talk on its own, is that the differential diagnosis of recurrent or persistent discharge is quite broad. And I've put some reasons at the bottom in the table. And simply increasing the dose of ceftriaxone may not be the answer. So in the old algorithm, we would just increase the dose of ceftriaxone if someone returned. it's still in the algorithm for men. It's not there anymore for women. But really simply increasing the dose is probably not going to be the answer in most cases with recurrent or persistent discharge. So there's a lot of partner dynamics and relationship dynamics involved, where people might get reinfected by the same partner or by a different partner. Often partner treatment is an issue, and that requires a different management. There might be a mismatch between etiology and syndromic regimen. So for example, if a man has a trichomonas urethritis, they're unlikely to get metronidazole, and therefore we can give syndromic regimen over and over. They might remain untreated. And then there's a complex etiology of discharge with a very broad differential diagnosis. So the importance of information and the complexity as well of treating, for example, bacterial vaginosis. So management of recurrent and persistent genital discharge is complex, and really without some additional diagnostic testing is quite difficult to find the right treatment and manage these patients properly. So that really puts us at a clear call for diagnostic tests in our STI programs. And World Health Organization put it together about 5 years ago, really recommending that countries start considering implementing diagnostic testing and etiological management of STIs, especially for high-risk populations. And they're busy now with the next 5 years global health sector strategy, which is pre-final now, and the call for diagnostics is only stronger in that new policy. And in South Africa, we also have a national strategy for STIs. It's not as well known or well circulated, but it is there. And also with a strong call to do diagnostic testing for our STI patients. So a lot of the preliminary data therefore came from studies with GeneXpert, where several studies implemented GeneXpert testing for Chlamydia, gonorrhoeae, and trichomonas in facility for testing STIs. So this was done in pregnant women, in adolescents, in PrEP users. There's a study. So there's several studies ongoing and completed where expert testing as a proof of principle for diagnostic screening and testing was done in healthcare facilities. And these can be done, as we know, with trained healthcare workers, turnaround time of less than 90 minutes, and it's feasible and acceptable in most populations. So it's pretty much back to the days of TB GeneXpert in these facilities 10 years ago. Now it really works. So if you do diagnostic screening or etiologic testing in pregnancy, for example, this was a study in pregnancy in Tshwane. We saw a strong reduction of STIs in women at time of delivery. If you would do diagnostic screening during ANC or etiologic management or syndromic management. So in this study, we saw a 10% lower prevalence of STIs at the postnatal visit, showing a reduction in STIs as a result of etiologic screening over syndromic screening. And some impact on birth outcomes as well. And there was this study done by the Caprisa team, also very nice, where they looked at HIV-negative young women and implemented STI screening as an HIV prevention effort. And what they showed was that if you actually do diagnostic screening at baseline, where they had a close to 60% prevalence of STIs, you could bring it back 3 months later to about 4%. So again, a strong reduction of burden of STIs in these young women through expert screening. So the intervention itself is really useful in reducing the burden of STIs and hopefully generating larger health benefits. So diagnostic management, I think, has three purposes or three reasons to think about. One is the diagnostic screening. So really the aim is to diagnose and treat anyone with asymptomatic infections. And the other component is to use diagnostic testing to optimize treatment of symptomatic patients, preferably by providing same-day targeted treatment and to inform partner management, but definitely in case of treatment failures to facilitate management and actually cure some of these patients. And different tests can be used for different purposes. So generally the screening, you would want to do a NAT, so a nuclear test, a molecular test, whereas for management of symptomatic cases, initially a more rapid test such as microscopy for presumptive diagnosis of gonorrhea, for example, would be more useful. Now, there's one thing that I do want to say about point of care tests. So the one big gap in the STI field is the lack of a good point of care test for chlamydia, gonorrhea, and trichomonas. And this is a point of care test that has been developed very recently by Find, which is a lateral flow assay. So it uses a similar technology as our HIV and syphilis rapid tests, but has an automated reader just to enhance diagnostic sensitivity. And we're busy evaluating this test for gonorrhea at the moment, and the data are really looking good. So hopefully we can work towards the first point of care test for gonorrhea in the coming years, which would really impact on our management of STIs. So the thinking with this one is you do the point of care test. If it's a negative, you would leave out ceftriaxone from the syndromic regimen, which would make a huge difference in our antimicrobial stewardship, as well as our treatment burden to patients. So the last thing I'm going to speak about is strengthening case management. It's very interesting. It's the STI guidelines globally have been very stable for a number of years. In the last 2 or 3 years, most countries, so the US through CDC, the BASH, the UK BASH, and the Australians, have suddenly revised their guidelines and made some big changes in their recommendations. We've looked at this as well when we were drafting the Southern African Clinicians guidelines. So if you look at the guideline changes globally, there's 3 major recommendations that have changed compared to practice a couple of years ago. So one is the recommendation for gonorrhea treatment, the second one for chlamydia, and the third one for trichomonas. And I'm not going to speak about trichomonas again, but it's really the recommendation to prefer a course of metronidazole over a stop dose of metronidazole for women with trichomonas infection. So I'm going to zoom in on the recommendations for treatment of gonorrhea and then chlamydia. So this is a good graph, I think, that I always like to show. It shows how quick antimicrobial resistance emerges in gonorrhea after the introduction of a drug in treatment. And the one thing that all these drugs have in common is that resistance emerged really, really quickly. So gonorrhea is able to develop resistance or acquire resistance very soon or very quick following exposure to a drug. So if you look at ciprofloxacin, for example, within 5 years of using it for gonorrhea, there was resistance. And even azithromycin, within 7 years, resistance was reported. So it shows how vulnerable our drug regimens are for gonorrhea. So one of the thinking 5 to 10 years ago was, why don't we use the same approach as we do for TB and for malaria, for other infections? Why not think of combination therapy, or HIV, I should say. So that brought up the concept of dual therapy for gonorrhea, which was introduced, and most countries adapted this dual therapy approach, where a combination of generally azithromycin with either cefixime or ceftriaxone was recommended to prevent or avoid the emergence of resistance. So when we look at the situation in South Africa, and these are data from national surveillance, but they're pretty much representative for the whole country. And even in a study now in the Eastern Cape, we see similar rates and a similar pattern. We see high rates of ciprofloxacin, penicillin, and tetracycline resistance in gonorrhea. So these drugs really shouldn't be used unless there's a very clear susceptibility profile. Well, in South Africa, we still see low rates of azithromycin resistance. So our data from sentinel surveillance really have not picked up, other than a couple of strains in 2008, have not picked up much azithromycin resistance. And the table at the bottom shows that ceftriaxone, the MICs are still quite low. So despite sort of the global concerns of rising antimicrobial resistance, and there was another paper this week on high rates of azithromycin resistance in the EU. South Africa is not doing that bad at the moment if it comes to resistance levels. There's two caveats though. And it is that in South Africa, we do sentinel surveillance in our general population. And there's really no data on antimicrobial resistant gonorrhea in our core groups, especially our men who have sex with men, and no data on oropharyngeal infection. And the reason that I mention these two is that these are the two groups where resistance is most likely to emerge first. So if we don't measure our highest risk population, it's actually difficult to say whether we are well on track or not. So there's a little bit of data. So this was a very small cohort that we did in Johannesburg a couple of years ago, looking at men who have sex with men, and where we picked up a 15% resistance of azithromycin resistance in genital infections at that time. So it does show that there may be differences between certain population groups in South Africa, and undoubtedly expanded and increased surveillance is required to close some of these data gaps. It also means that our recommendations for treatment of gonorrhea are quite difficult because there's not a lot of data on these higher risk groups. So what did the rest of the world do? So the rest of the world decided to move away from azithromycin. And the reason is that despite the theory of dual infection and protection of emergence of resistance, these effects were actually never shown. So this was a theoretical benefit of dual therapy that was actually never confirmed in any practice or clinical trial. And people saw or observed increasing rates of azithromycin resistance in gonorrhea. So despite dual therapy, the azithromycin resistance actually is emerging. And the thinking behind it is that it has to do with different pharmacokinetics and dynamics between ceftriaxone and azithromycin in the genital tract, and especially the azithromycin tail after the ceftriaxone. So the world is moving away, other than the Australians, from dual therapy actually to monotherapy with ceftriaxone. So CDC, the US gives now 500 milligrams of ceftriaxone, and the British have gone up to 1 gram of ceftriaxone based on the higher MICs that they observe at their facilities. So with the guidelines groups, we debated this as well, and our suggestion or recommendation in the clinicians guidelines will be to look at a 500 milligram targeted ceftriaxone treatment for those with a confirmed gonorrhea infection. So based on the relatively low MICs, but also the lack of knowledge what's happening in our key populations, we think 500 milligrams would be fine. With the addition that if anyone diagnoses a pharyngeal infection, you should probably go up to 1 gram of ceftriaxone for appropriate treatment. Second major change globally is the move away from azithromycin to doxycycline for treatment of Chlamydia trachomatis. So a couple of years there was a meta-analysis published. And most countries at the time use azithromycin as first-line treatment for chlamydia. There was a fierce debate for several years about the efficacy of azithromycin and doxycycline for these infections. So this meta-analysis showed that the efficacy of azithromycin was actually lower, or doxycycline actually had a higher efficacy for treatment of urogenital infections, with an 8% failure rate on azithromycin, only 3% failure rate on doxycycline in men. So in men with urogenital chlamydial infection, doxycycline actually does better than azithromycin. And this effect wasn't as clear in women. So in women, it wasn't a significant difference, but the failure rate on azithromycin was slightly higher than that on doxycycline. However, in women, there's another issue, actually two. And that starts with rectal infections. And these are data that were published last year. Again, after a lot of debate on the optimal treatment for rectal chlamydia. And these data showed a higher efficacy of doxycycline than azithromycin for rectal chlamydial infection. So a 97% cure rate versus 76% cure rate. So a substantially higher efficacy of doxycycline for rectal infection. So basically, someone with a rectal chlamydia infection should really get doxycycline and not azithromycin. Now, why is this important to our setting? So one of the reasons is that untreated infection is associated with an increased risk of HIV infection. So both gonorrhea and chlamydia, as you can see on the left. So there's a 2 to 3-fold increased risk of HIV acquisition in case of unprotected anal sex. But the other reason is really that it's a cause of recurrent and persistent discharge in women. And what happens is that because of the close proximity of the vagina and the anus, women auto-infect between the two anatomic spaces. And that's one of the reasons that we find asymptomatic or even symptomatic chlamydia or gonorrhea in women who don't engage in anal sex. So anal sex is not necessarily a predictor for anal STIs simply because of the close proximity. So because of the lower treatment efficacy for rectal infection, it means that a number of these infections wouldn't be treated appropriately with azithromycin and result in recurrent cervical infection in women. So basically, although in women the efficacy of doxycycline may not be significantly higher for concerns of autoinfection between the rectum and the vagina, doxycycline is preferred over, or should be preferred over azithromycin as well. So most countries, so the US, the UK, the Australians have moved back to doxycycline, which was 10 years ago the first choice before we moved to azithromycin. And our thinking with the guideline committee is also to move back to doxycycline as the preferred option for targeted treatment of chlamydia, acknowledging that a course of antibiotics is not always as easy as a stud dose. So in settings or in individuals where a stud dose might work better, that can still be considered. And one of the other reasons that I didn't mention is that there are concerns about rising rates of azithromycin resistance in Mycoplasma genitalium, which is another STI with a similar presentation. So that's really the three reasons to move from azithromycin to doxycycline. So in summary, I think we have a high burden of untreated STIs. There's a bit of a success story on syphilis, but I think we still have quite a few things to do to reach our elimination targets. And I think it's important that we move from our current situation to really to a best practice, which should include really working on the basics and implementing appropriate STI screening, which can be provider initiated or diagnostic, and really look at the introduction of diagnostic tests for targeted treatments, both of symptomatic individuals and those with a treatment failure. And hopefully our guidelines will help to strengthen case management and improve treatment outcomes. And in that sense, I think an important part that's missing in our healthcare system is the capacity and the knowledge to manage these referrals. So it's very easy to say at a primary healthcare level, refer to the hospital, but without knowledge or an access to diagnostic tests, it's actually quite difficult to manage individuals with persistent symptoms. So without a doubt, additional capacity building and access to basic diagnostic tests is essential. So what we've done is we've tried to capture some of these suggestions in the guidelines that Jeremy mentioned. And we've got a nice draft version of the Clinician Society guidelines currently. That's under external review at the moment. So hopefully we can put these out in the coming couple of months. And it's another piece, hopefully, of the puzzle to improve our STI outcomes. And with that, I would like to thank you.
Wonderful, wonderful talk, Remco. Thank you so much. I've got messages on my phone and there's some in the chat as well. Really hugely appreciative. It's certainly one of the best talks I think we've ever had on STIs. And it does highlight, I think, to many of us, and myself included, how many errors effectively we made over the years and how much better we could be doing this. And it's really, really important. And just another heads up, as Remco said, to be on the lookout for these guidelines in the next few months when they do come out through HIV Clinicians Society. It really is, I think, filling in a really important diagnostic hole, or let's say management-wise hole that we have in the country. And for the reasons you said, I wanted to ask, I mean, clearly moving, say, Department of Health from a syndromic management to requiring diagnostics and focus is a lift, is a big lift financially, and obviously there's changes, but I mean, how solid is the case to say, well, look, if you invest financially in this and you are able to decrease STIs over the medium term, let's say, which will obviously save money in the long term. I mean, from a purely financial, and I know it's not a purely financial thing because there's many other considerations in individual patient care, but from a Department of Health viewpoint, is there a strong case to be made for that, or is that a bit theoretical?
I think it's actually the main gap at the moment is a proper investment case. I'm working with some of the group in the US, UK, and Switzerland, looking at some of the burden of disease estimates globally, and the challenges in actually estimating the impact of these STIs. So there's a lot of associations, but because of the strong epidemiological link between, for example, HIV and STIs, it's not so simple to put a number or a figure to it. But it also talks, I think, to some of the limitations in the system. So, for example, if you look for proper data on ectopic pregnancies and mortality of ectopics, you can't find it. It doesn't exist. The same for birth outcomes. I mean, it's largely research data. There's some. I mean, South Africa does very poorly on birth outcomes. Actually, on low birth rate and preterm deliveries, we're nowhere near the development goals. But the attributable proportions are not well understood, simply because of inflammatory pathways and lack of data, especially impact data. And I think that's the main thing really to close, is not only to look at what does it cost, but especially to do those cost effectiveness analysis. And that's one of the reasons we do the trial now, for example, here in East London, looking at STI screening in pregnancies to really measure not only reduction in STIs, but hopefully being able to document the effect on birth outcomes. Yeah, it's multifactorial, so it's not a one-on-one. It's the same with HIV prevention. It's not a one-on-one. I mean, there's good data from Lee Johnson from a number of years ago, showing that 2/3 of the HIV transmissions are linked to STIs and bacterial vaginosis. That was in the early days of ARVs. To my knowledge, there's no more recent data. So that investment case, I think, is the main bottleneck at the moment.
And then I'm just going through a couple of questions. I've muted myself, sorry. I'm just going through some of the questions in the chat. There's an interesting one from Lucille about genital schistosomiasis. It's obviously not an STI, but it's got a link to STIs in the particular HIV in the geographically at risk area, because that's something South Africa also doesn't do well, I don't think, in terms of that. Is there any link to STI care that, I mean, you would hope you'd get people before they developed STIs, but is there, what sort of overlap do you see in this country in terms of potential resources and or clinic visits and or other things like that?
Yeah, I think it's it's a complex question, I think. I mean, we know genital schistosomiasis does impact on birth outcomes as well. We know it plays a role in discharge, so it should certainly be included in the discharge etiology. For example, here in the pregnancy trial, we do look at schistosomiasis as well. Haven't found much here in East London, fortunately. But it's a forgotten entity, it's overlooked without any doubt. So definitely in the areas with where you have schistosomiasis, I would take a good look at it and include it in the differential. But again, I think it talks to having diagnostic resources and but also educating that people actually recognize these cervical lesions when they see them.
Yeah, no, good point. Nina's asking about, are there any plans to expand the gene expert testing at the moment, for the STIs? What sort of capacity is there, and is DOH planning on pushing it further, or is that very much contingent on them changing their kind of general approach as a whole?
What I pick up, but it's not a commitment, but at least is that since the last year or two, and I'm part of these technical working groups and some of the national meetings, there slowly is movement towards that shift. I think the big question mark is who's going to pay for it. Yeah. And the same for the gene expert. I mean, we all acknowledge the TB capacity that's there, but I mean, if you start screening people for STIs, the numbers are far higher than we test for TB at the moment. So it's a huge logistic and infrastructural investment that would be required. Personally, I'm not convinced that gene expert is the answer. I think there's other high throughput assays and tests that require less volume in resources that actually probably have a much more feasible setup. But it's another question, should this be done at a point of care? Should this be done in the lab? Will people come back for their results? Are people prepared to wait for their results? And I think scaling gene expert, if anything, might be an intermediate. I don't think that's the long-term future, to be honest.
Yeah, that's an interesting point. And I think also your other related point, which was made well earlier in your talk, was about also setting the patient expectations that, if we are going to, at least currently before we change, if you're giving, say, stat dose of metronidazole, explaining that does have a non-trivial failure rate, and that, just making sure they're still connected to care, so that if that happens, they don't get discouraged and fail to return. And, because that, as you say, you're almost compounding the problem by as you said, we've got, or let's choose a different example, the doxycycline a week versus azithromycin stat. And yes, the adherence rate to a week is perhaps less, but at the same time, the failure rate is a lot less, and the adherence rate after failure is predictably terrible. So there's a lot of other factors. It's not just a simple thing. It's a pity, because it would be lovely if the stat dose worked just as well, but it doesn't. That's wonderful. I'm just looking through. I think that's all the questions that have come up, but I'm having to wade through all the comments saying thank you so much to find questions. So we should take that as a very, very good sign. So thank you very, very much, Remco, for your time. As you can tell from his talk today, Remco is an absolute expert in this field. So we look forward to the guidelines coming out and also to engaging, I'm sure, with you in the future about other aspects of care here, because it is such a difficult topic in many ways, and done so badly in South Africa that we've got a long way to go. So hopefully this is the start of something moving in the right direction. So thank you hugely, Remco, for your time. Hugely appreciated.
Definitely. Thanks, Jeremy. It's been a pleasure.
Sure, thanks.